we can decide. And also the transfer, whether patient needing a transfer to any tertiary care center or any other escalation of the therapy. And also very important, when you get over, when you giving a handover, when you present, we go for a appropriate and detailed handover to your handover, or you present to your senior doctor in a concise, palatable way. So these are the 5 stages of care. That's a blueprint we stick to. If there is any question, if you have a question, I'm happy to answer through you can text message in a comment, then I can answer. So if I summarize what we have discussed, we stick to blueprint. Any deteriorating patient, we stick to blueprint. 5 stages. Charge the patient, initial stabilization of the patient by going through the position and ABCDE approach, then directed history and examination, commencement of specific treatment, ongoing care. So this approach can be used by any doctor with the basic diagnostic skills and experience because it's systematic, easily learnable, and also readily recalled under stressful scenario. That's the most important thing. You might have all the distinction in all the clinical field, but when it comes to a patient in front of you, if the patient is deteriorating, if you can't recall, it goes in vain. Thank you. So there are some questions. So I will go through the questions and answer. First, this previous recording, can you upload the recording to the YouTube? That I think we will discuss with the Ministry of Health, and we will tell you guys what thing. I'm happy to share my presentation with you guys. I will post my email address. If anyone wants my presentation, I'm happy to share, no problem. And let me answer a few questions because we have some time. Right, so yes. Question is, when we use a CABCD approach, yes, when it comes to a trauma, I don't want to put those things and complicate you guys. When it comes to trauma, sometimes we go for CABCD approach. C for not just a circulation, we go for catastrophic bleeding. So imagine if the patient comes with the trauma, with the carotid artery or the internal jugular vein is being cut, and there is a spurting of blood, then what do? No airway breathing, then no. First you have to stop the bleeding. Not the simple bleeding. If there's a catastrophic bleeding, yes, you control the catastrophic bleeding. Then airway breathing and circulation. So sometimes, yes, we do go for ABCD approach when it comes to a catastrophic bleeding. So how do you combine this blueprint with the death confirmation? There is actually, if the patient comes to you, and if the patient doesn't have a signs of life, I think you will have more sessions on the ALS as well. So if the patient is not responding, if the patient is not breathing, and if there is no central pulse, it's a cardiac arrest. Then you might have to start a CPR. I think that will be discussed in the subsequent lectures. What's advanced life support? How do you go for an advanced life support? So death confirmation. So if somebody asks you about the death confirmation, that of course once you have when you have unable to rescue the patient, then you go for a death confirmation. You see is there is any signs of life, is there is any central pulse is there, if the patient is breathing or not, whether is there is any heart sounds are there or not, and pupils are fixed and dilated or not, because we don't want any hypoglycemic patient to be confirmed as death and put it into the mortuary or anything. Yes, but it's very simple, guys. If the patient is not breathing, if there is no central pulse, and if there is no heart sound, if you put a ECG monitor, there is no ECG, the electrical activity of the heart, and pupils are fixed and dilated, and patient is, so then you don't have to do a sugar to confirm that. So these are the signs of life. There are some specific cases being asked. In a patient with a heart failure with the low blood pressure, how do you position the patient and fluid management? Yes, that's a bit specific one. That's out of scope of this one, because I have another 5 to 10 minutes. I think I can go ahead. So yes, if the patient is um, hypoxic and hypotensive, then yes, then we have to decide. What we do is we start inotrope to increase the or vasopressor to increase the blood pressure. Then we position the patient appropriately, and there are other management, IV furosemide, IV GTN, and continuous positive airway pressure ventilation, non-invasive ventilation. CPAP is a life-saving for acute cardiogenic pulmonary edema. So if there is acute MA and MI, myocardial infarction, and if there is a facility of primary PCI, do we need to inform? Yes, actually, those are unit policies. Please check with the unit policies and your emergency department and the ETOs. So if the patient comes with the acute MI, and if you could wheel the patient to the cath lab within 2 hours on arrival, within 2 hours on arrival, then the primary PCA is the best way. So you would be able to immediately informing to your seniors. Right. So there is another question that's I think relevant for this one as well. How do you position the patient, pregnant patient, while resuscitating? So how do you position? Sometimes the best one, you put the patient in the uh, left lateral 45-degree tilt, but very difficult to get the wedge to put it. Sometimes we put the pillows. Or the easy way is, I will ask one of the staff to hold the abdomen, move the abdomen. If there is a like term mother, gently move the abdomen. Uh, Somebody to pull the abdomen, especially the gravid uterus, to the side. So that will prevent the compression of the aorta cable. Aorta cable, that means IVC and the aorta compression will be prevented. So what involvement, what avoid spinal movement? Yes. So if there is a cervical spinal injuries, then if you are suspecting a cervical spine injuries, yes, then we have to protect the cervical spine, starting from a manual inline stabilization, followed by a collar, and very gentle with this one. So in airway maneuvers, yes, we only go for a jaw thrust. So what level of stabilization you should we do in a stroke patient who is having a high blood pressure and yes, we stick to the basic, guys. You go for initial stabilization in an ABCD approach, and you stabilize the airway, breathing, circulation, and disability. Then you wheel to the patient to the non-contrast CT brain. So if the GCS is very low, you might have to even consider to intubate the patient before going for the NCCD brain. That's all are very arbitrary things, and you have to check with your unit facilities as well, whether CT is available in your hospital, or you have to move, how far away from your CT, away from your hospital, all matters. So there is another question: the pregnant woman, how do you give a CPR in the same way or not? There are different protocols for the pregnant ladies that will be more advanced one, guys. But there will be, I think, it might be touched in a ALS scenario. I will convey the speaker who gives the ALS, advanced life support. But the basic principle, we first care about especially the position the patient and starting a CPR as usual. And if the patient is not retaining a certain, there is a thing called emergency cesarean section. Cesarean section. I think because of the time factor, let me I think there are lots of flooded questions are there. Very unfortunate to tell answer each and every. Unfortunate to answer each and every question, but that shows the enthusiasm and lots of questions. Don't worry, guys. You are not alone. There is a hierarchy, there is a system here. Interns are there, then senior house officers are there, registrars are there, senior registrar, maybe in not all the unit, there are registrar, senior registrar, consultant are there. Everyone will help you. So don't worry about, so you go for a systematic approach and call for help. All the best. So let me conclude my lecture, and the next lecture would be is going to be Arrhythmia by Tushara Vidyanapathan. Over to you, Tushara.
Thank you very much, Prashant.
Right. Sorry about that. Can you hear, Dr. Shah?
Yes, I can hear.
Next lecture is by consultant emergency physician Dr. Tushara Vidyanapathan, management of arrhythmia. He is a consultant emergency physician at DGH Matara. Over to you, Doctor.
Thank you very much, Dr. Roshan. Good afternoon, everyone. My name is Tushara Vidyanapathan. I'm the consultant emergency physician in District General Hospital, Matara. First of all, I would like to welcome you all to the new specialty and greetings for the new and big step you are going to take in near future. Yep. Emergency medicine is a new specialty. This picture will give you a clear demonstration about what it is. We are new to the field in Sri Lanka, even though it's a very mature specialty in other countries. So our role mainly, we manage all kind of patients presenting to hospital from birth to grave. Resuscitation of unstable patients, and we stabilize. Prashant talk much about this. Management of time critical patients like STEMI, stroke, polytrauma, and manage all patients in the emergency department and discharge, ensuring patient safety. Those who need more time to sort their problems, admission to short stay unit and discharge. Those who need specialized care will admit under respective specialties. In hospital and out of hospital patient retrieval also a component of emergency medicine. This is just a brief what is emergency medicine is. There are a lot of advantages having emergency physicians in hospital. It may help to timely management of emergencies, prevent unnecessary hospital admissions. All investigations done in emergency department, and if necessary, will discharge patients, reduce hospital expenditure, and save much money from annual hospital budget. We are trying our best to minimize hospital overcrowding. So today I'm going to I just gave you a brief introduction about who emergency physicians are. My topic, I'm moving to the my proper topic, cardiac arrhythmia. Cardiac arrhythmia, it belongs to electrophysiology, which is a separate specialty. But being accident and emergency department doctors, or any doctor who is involving with patient care, should be able to manage basic cardiac arrhythmia, which need to save their lives. I think you might quite familiar with this algorithm. I'm going to discuss mainly throughout this lecture. I'm going to discuss this algorithm with you. Emergency department work, or when you start your career, when you are working in a medical ward, pediatric ward, obstetric ward, if there's emergency, it's mainly a teamwork. Any unstable patients coming in our departments, if we are getting any kind of unstable patients, we work as a team. We have prior dedicated roles. We do assess airway, monitor respiration with oxygen saturation, monitor ECG, blood pressure, and record 2 lead ECGs, obtain IV access with basic blood samples for investigations with venous blood gas, try to identify any treatable cause like electrolyte abnormalities, stocks, any other treatable cause. This is the structured basic approach. So, moving back to this slide, you are getting patients with palpitations, chest pains. When you approach to these patients, they are having some sort of a cardiac rhythm abnormality. You need to assess basic ABCD approach in a way that what I explained. If you get a patient with arrhythmia in your ward, you need to do structured approach, ABCD approach. You need to address killing things first. That means airway is the first thing that kills person. Unstable, if your patient is unstable, if you cannot properly manage airway, that patient may die without prior to addressing other components. So likewise, you need to go through the structured ABCD approach. Right now, patient coming to you or call for you to come and assess patient with arrhythmia. Any patient with fast rhythm, first thing you need to check whether this, once ABCD approach is done, you need to check whether this patient is hemodynamically stable or unstable. How do you decide this patient is hemodynamically unstable? Always, not only hypotension, there are other components also. Your patient may be in shock. We talk about 4 features: shock, syncope, failure, and ischemia. Your patient may be in shock. Patient may have syncope. Patient may be in heart failure, or patient may have ongoing myocardial ischemic pain. These patients are considered as hemodynamically unstable patients. In these situations, you need to control the rhythm irrespective of the type of rhythm. So what you need to do is, your patient needs appropriate sedation if your patient is conscious. So you need to give either propofol, or commonly available one in medical wards are midazolam, or you can give fentanyl. Propofol is usually easily not available in your wards where you are doing your internship. It's commonly available in emergency department and theaters. You can use midazolam if your patient is conscious. You need to synchronize, and you need to cardiovert these patients. If shock, you can go up to 3 shocks. If patient is shock resistant, you need to give IV amiodarone, and IV amiodarone 300 milligram over 10 to 20 minutes. These doses should be at your fingertip when you are managing your emergencies. Then you need to give another shock. Most of the time, the patient may come back to normal sinus rhythm. If not, then you need to start amiodarone infusion, and if your patient is shock resistant, you may need to seek expert opinion. Okay. So this is the defibrillator available in my department. Once you start your internship, you need to check whether there's any functioning defibrillator in your ward. It should be daily checked by allocated nurse to see whether it's properly functioning. Otherwise, if patient crashed in front of you, if it is not working, you become helpless. So it's a nurse's duty to check whether it's properly functioning, and they need to check emergency trolley, where all the emergency medications are kept in the ward. Right. If your patient is stable, I told you about 4 components. Any patient coming with arrhythmia with 4 features: shock, syncope, ischemia, and failure, they are considered as hemodynamically unstable. If those 4 components are not there, you need to assess the patient's rhythm. You need to assess the QRS complexes. So normally, QRS complexes are less than 3 small square size. If it is more than 3 small square, it's considered as broad complexes. If it is less than 3 small squares, it's considered as narrow complexes. When the rate is fast, it's considered as narrow complex tachycardia or broad complex tachycardia. Then we need to assess. I'm going back to the first algorithm here. We check whether patient is hemodynamically stable or unstable. If your patient is hemodynamically stable, then you are going to see whether QRS complexes are broad or narrow complexes, right? Now we are going to talk about the left arm, about broad complexes. Sorry. And on the right hand side, we are going to discuss about the narrow complexes. Then the hemodynamically stable patients, we are going to further divide narrow complexes into 2 categories. Either these narrow complexes are regular or irregular. Then you need to go through a particular path when you are managing the arrhythmia. So now I am going to discuss about the hemodynamically stable patients who are having irregular narrow complex tachycardia. It is probably considered to be atrial fibrillation. You should be able to identify fibrillatory rhythm, and our first line treatment is IV max sulfate. We are giving IV max sulfate over 2 to 4 grams over 10 to 20 minutes time. But we can't see obvious rapid action within seconds, but it will take some time. Within half an hour to 1 hour's time, patient may settle. If not, we need to move on to the other management strategies. So if your patient coming with palpitation or hemodynamically stable irregular narrow complex tachycardia, if your patient is telling it's clearly that this palpitation started less than 48 hours time, and this is atrial fibrillation, you need to we can cardioverse this patient and take them back to normal sinus rhythm. If it is less than 48 hours, we do synchronized cardioversion. If it is more than 48 hours, we need to think about whether this patient need rate control. If it is a fast rhythm, we need to control the rate, or whether we are going to control the rhythm and going to take these patients back to normal sinus rhythm. It depends on patient characteristics. So you need to read about what characteristics may leading to rhythm control and what characteristic leading to rate control. If you are going for a rhythm control, you need to cardiovert, but if it is more than 48 hours, you cannot do immediate cardioversion because they may have blood clots inside their heart, and once cardioverted, these clots may shoot and they can have cerebral infarctions. They can have a lot of complications. So you need to anticoagulate and you need to do elective cardioversion on these patients. If you are going for a rhythm control, that is the path you are following. If you are going for a rate control, you can use beta blockers, diltiazem, or if your patient is having features of chronic heart failure, you need to consider IV digoxin or IV amiodarone. If you are if you are managing these patients in a rhythm control way, always you need to assess thromboembolic risk, and if they are having thromboembolic risk, they need to take anticoagulant lifelong. There are a lot of scoring systems to calculate thromboembolic risk in patients who are having atrial fibrillation. Depending on that, patient may need anticoagulation if you are going to keep this patient in rate control. That is how you are going to manage atrial fibrillation. During this time period, I can give you a very brief account on this arrhythmia, but you need to read around this. This is just a guidance. Then, if you take ECG features of atrial fibrillation, it's a irregular rhythm. Sometimes you are not quite sure whether it's a regular or irregular. In this case, you need to mark R waves with a pen, keep a piece of paper along here, and mark with a pen at the edge of this piece of paper. Then take that piece and keep somewhere else and check these marked are overlapping with the R waves. If these overlapping, that rhythm is regular. If not, then rhythm is irregular. So atrial fibrillation is irregular rhythm. You can't see obvious P waves, but there are some fibrillatory waves which may mimic P waves. You have to be very careful, which may lead to misdiagnosis. Then you can't see clear isoelectric line most of the time. Absence isoelectric baseline is there. Variable ventricular rate. Clearly you can see ventricular rates are variable. And QRS complexes are usually less than 3 small square size small unless pre-exciting bundle branch block is not there. Fibrillatory waves may be present and can be either fine or cause fibrillatory waves. Okay, so even if you can't keep everything in your mind, once you started your internship, at least you should be able to identify what rhythm, you should be able to identify atrial fibrillation in an ECG. Then your senior house officer, registrar or senior registrar may help you in further management. That's the minimum requirement if you are starting, when you are starting your internship, considering atrial fibrillation. So then I'm going to discuss the other component, hemodynamically stable patient coming to you with regular narrow complex tachycardia. Regular narrow complex tachycardia. Regular narrow complex tachycardia, we'll take, unless proven otherwise, it's a supraventricular tachycardia, SVT. If your patient is hemodynamically stable, you can try vagal maneuvers. Vagal maneuvers are carotid massage provided no carotid bruit. When you are giving carotid massage, you need to be very careful in elderly. If they are having carotid bruit, there may be atheromatous plaque, and plaque can shoot. Patient may end up with cerebral infarction. Or you can ask your patient to perform Valsalva maneuver, which is very well described in your physiology book. Now the latest one is modified Valsalva maneuver. Modified Valsalva maneuver, which carries higher success rate compared to Valsalva maneuver. I'm not going to describe how to perform modified Valsalva maneuver, which is available in YouTube. All of you are having smartphones. Just search modified Valsalva maneuver in YouTube. You can find how to perform it. Then in pediatric patients, submersion in ice water also tried. But earlier we used eyeball pressure to control supraventricular tachycardia. It's strongly discouraged and contraindicated. There were several reported cases of globe rupture in the past. So no longer eyeball pressure is used to control, manage supraventricular tachycardia. If these vagal maneuvers are failed, you need to move for pharmacological treatment. Provided your patient is not having, you can give IV adenosine. IV adenosine is ultra short acting medication which need to be given very close to your heart. It can be given either large single bolus dose, or you need to connect three-way tap, and at one end you are pushing the medication, with other end it's flushed with a large volume of like 10 or 15 ml of saline. Latest study has shown diluted large bolus of adenosine, the adenosine dose diluted in a roughly about 20 ml. If you can give it as a single bolus, also effective. But this is, I'm not practicing this so far, but I'm still using the conventional way of management. That means giving adenosine at the one end of three-way tap and the fluid saline bolus from the other end of the three-way tap. So you need to select vein which is very close to the heart. If it is in a wrist, when these medications reach into heart, their action is over. Right. So remember to find big vein close to heart. Could be external jugular vein or cubital fossa vein. Cubital fossa vein is ideal. Okay. If your patient is not responding to adenosine 6 milligram, you can double the dose. You can give 2 doses, 12 milligram 2 times. If patient is not responding, you need to go for electricity. If your patient is having bronchial asthma or COPD, adenosine is contraindicated, you can give IV verapamil 5 milligram most of the time. With 2 to 3 minutes time, their supraventricular tachycardic rhythm may terminate. If not settling, always there may be possible atrial flutter. You need to control rate with beta blockers. If this patient is not settling, always you need to seek your senior help. This is just a rhythm of a supraventricular tachycardia. Patient who are not having bundle branch block. Bundle branch block means right bundle bar or left bundle branch block. If your patient is in supraventricular tachycardia, you can see it's a regular rhythm. Narrow complexes and rate is more than 100. Usually those who are having supraventricular tachycardia, their rate is very fast. It's usually more than 180 beats per minute. The heart is, the rhythm is running in a very fast rhythm. Usually it's more than 180. And you can't see any visible P waves. So these are regular narrow complex tachycardia, which is described as supraventricular tachycardia. I'll answer your questions at the end of this lecture. So now I'm moving to broad complex tachycardia. So I'm going to talk about hemodynamically stable patients with regular broad complex tachycardia. Regular broad complex tachycardia, it could be VT, or if it is an uncertain rhythm, treatment is IV amiodarone. If patient is known to be supraventricular tachycardia with bundle branch block, it's a regular broad complex tachycardia. So you need to treat as regular narrow complex tachycardia. Ventricular tachycardia is a broad complex tachycardia originating in ventricles. Their rate is usually around 160 to 180. Their heart rate normally doesn't go beyond 200. There are several different varieties of ventricular tachycardia. There are so many varieties, which is more than the simple ventricular tachycardia which you learned in medical school. The most common being monomorphic ventricular tachycardia. This is a regular broad complex tachycardia. There are a lot of features suggestive of ventricular tachycardia. I told you there are different varieties. You need to read around this. This is to improve your enthusiasm on reading about ventricular tachycardia. They are very broad complexes. Rate is usually around 160s. Absence of typical right bundle or left bundle branch morphology. They have extreme axis deviation. You can see AV dissociation, capture beats, fusion beats, positive or negative concordance throughout the chest lead. That means leads V1 to V6 show entirely positive R waves or entirely negative complexes, which is suggestive of ventricular tachycardia. There are other features, Brugada sign, Josephson sign, RSR complexes with a taller left rabbit here. This is just to highlight this point for you to read around this and read bit about different varieties of ventricular tachycardia. So other varieties, supraventricular tachycardia with bundle branch block, which also comes as regular broad complex tachycardia. You need to read around how to identify this. Now I'm going to talk about the irregular broad complex tachycardia. Irregular broad complex tachycardia, always you need to seek expert help. They may have atrial fibrillation with bundle branch block. If it is so, you need to treat as for irregular narrow complex tachycardia. Or if patient is having AF with pre-excitation, WPW, you need to consider amiodarone. You cannot use rate control agents like beta blockers or other rate controlling medications. Their alternative path may get activated and end up with ventricular fibrillation. That means patient is going into cardiac arrest. So other varieties, polymorphic ventricular tachycardia is a form of ventricular tachycardia in which there are multiple ventricular foci within the resultant QRS complexes varying in amplitude, axis and duration. The commonest type of polymorphic ventricular tachycardia is polymorphic ventricular tachycardia. Torsades pointes are the specific form of polymorphic ventricular tachycardia occurring in the context of QT prolongation. It is very common among patients coming with tricyclic antidepressant poisoning, TCA poisoning. It has a characteristic morphology in which the QRS complexes twist around the isoelectric line, like in this diagram. It's a commonly associated with QT prolongation that you need to cardioverse these patients. You need to give IV max sulfate over 2 grams over 5 minutes. Even you can repeat MEG sulfate. The treatment is MEG sulfate. This Tosade pointing. It's a kind of polymorphic ventricular tachycardia. These are the monomorphic ventricular tachycardia and polymorphic ventricular tachycardia are the two types of ventricular tachycardia commonly come across when you are working in medical wards. For tachycardia, if you have any doubt, you need to manage as VT unless proven otherwise. Any resistance case, electricity has a place. If you are not sure what's going on there, if your patient is hemodynamically stable, always seek expert help. If your patient is hemodynamically unstable, you can't wait till your senior house officer comes and help you when they are on call, and if they are taking long time to come, you can't wait. You need to cardiovert and save the life. If your patient is hemodynamically stable, you can communicate to your senior house officer, registrar, or a senior registrar, even with the consultant, and get their expert help in managing your patient, because these are life-saving measures in acutely unwell patients. So that's all about the tachyarrhythmia management, and I'm going to talk about the bradyarrhythmia. It's also the same. If your patient is having a bradycardia, always you need to go through the ABCD approach. Give oxygen if appropriate, and monitor ECG, blood pressure, saturation, and identify any reversible causes. For example, any patients coming with bradycardia, your first differential should be either myocardial ischemia or electrolyte abnormalities or poisoning. Those are the very common things. Common things are first. Then you need to think about other causes of bradycardia. Then you need to check adverse features, which I told you when at the discussion of managing arrhythmia. You need to see adverse features: shock, syncope, myocardial ischemia, and heart failure. Any features are present, you need to give IV atropine. Western guideline says 500 microgram, but we are having 0.6 microgram atropine vials. We are giving 0.6. If there's a satisfactory response, we'll assess this patient for the probability of asystole. If there's no risk of asystole, we observe these patients in ward. After that, you can take discharge decisions with your seniors. If there's a lot of risk factors for asystole, or if there's no satisfactory response with IV atropine, you need to go for the interim measures. You can repeat atropine up to maximum 3 milligram. That is the point where you are getting maximum parasympathetic block. And even you can use IV adrenaline. Be careful, always get your senior support. Or if no adequate response, you can start IV isoprenaline, or you can go for transcutaneous phasing if facilities are available. If there's with three doses of atropine, if you reach to maximum dose 3 milligram, if no desired response, always you need to seek expert help. There are some alternatives. You can use aminophylline, dopamine, glucagon, which are not commonly available in our medical wards. This is the machine available in my department. We use this if our patient is not responding to atropine and patient is having symptomatic bradycardia. We do transcutaneous phasing. We'll select the pacer mode and we paste electrodes in infraclavicular and apical positions, select desired electricity, and we start phasing if our patients are hemodynamically compromised. You need familiar with the machine, and if we are doing transcutaneous phasing, patient needs sedation because patient is getting vigorous muscle contraction, which is very painful. This is a temporary measure, and till you arrange permanent measures for the management of bradycardia. That is what I wanted to discuss with you. I'm just moving with the questions. There were so many questions. I will not be able to answer all questions. Somebody has asked, sir, finally, please give a brief talk on how to be an emergency physician. Once you completed your internship, you need to have 1 year post-internship. Meanwhile, go through the Postgraduate Institute of Medicine website. They are advertising exam times. If anyone interested, I'll post my email address. I'm happy to reply everyone. Sir, how a patient can present with shock with normal blood pressure? How can we identify they are in shock? There are patients presenting to emergency department, they are having normal blood pressure, but they are in shock. That means if I told you that we are doing a venous blood gas, you know that cyanide poisoning, but blood oxygen level is fine within normal limit. Tissues cannot extract oxygen. There's a tissue level hypoxia. So this is one entity like that. Patients are in shock with normal blood pressure. That means if you do a blood gas, you can see their lactate level is rising. That means anaerobic metabolism is taking place. They are in shock. Someone has asked how much midazolam. Usually we are giving 2 milligram, but we titrate dose according to the patient's response. We used to give 2 to 5 milligram depending on patient's response. If patient is elderly, if you give all of a sudden 5 milligram, they may end up with respiratory failure. You may need to do a bag mask ventilation. So you have to be very careful, always titrated dose. If patient has low BP, but not in shock, do we consider unstable or unstable? If patient's blood pressure is low with fast rhythm, definitely it's considered as unstable. Definitely it's considered as unstable. No stable low, unstable ambiguity. Anyone coming with arrhythmia, with hypotension, you need to consider them as unstable. Someone has asked physiology behind giving max sulfate in AF. Actually, this came with evidence-based studies. It's uncertain the pathophysiology, physiological mechanism. One mechanism, it's the research publishers assume that most of the people who are having atrial fibrillation are magnesium depleted. That's the only reason they have described with these studies. Then how to decide whether need rate control or rhythm control? You need to read around this. If patient is having multiple comorbid diseases, valvular heart lesions like that, there are a lot of criteria. You need to read around this. It's difficult. If you are really interested, just drop email. I'll answer your question and I'll direct you reference materials. Same question asked again. Which is the priority? It's a decision taken by the clinician whether this patient needs a rate control or rhythm control. If it is a recurring with multiple comorbidities, usually they are going for a rate control rhythm. It needs to be decided with a certain criteria. As I answered for the previous question, just read around this. What is the benefit giving max sulfate before giving rate control medications? It has a very successful rate. And giving 2 grams of max sulfate, if your patient is having good urine output, good renal functions, giving 2 grams of max sulfate will not cause much harm. But giving rate control medication, sometimes their blood pressure can drop. There are a lot of other medication related issues. Compared to that, we prefer to give IV max sulfate. Someone has said smartphones are expensive. Yes, exactly. But most of you all are having, with your internship, you will get a satisfactory allowance for that. So in bradycardia management, does give all drugs in interim measures? No, we are not giving all drugs. We are giving one by one and trying whether the patient is improving. Atrial fibrillations, we giving max sulfate before rate control. Yes, that is our practice, but you need to follow your consultant and always get directions. Being emergency physicians, our first line is IV max sulfate in atrial fibrillation. If the patient is hemodynamically unstable with bradycardia, no, we don't cardiovert. They're asking hemodynamically unstable patient with bradycardia, do we need to cardiovert? No, no. The purpose of giving electricity is to control the fast rhythm and establish the good contraction in the heart with very controlled manner. In bradycardia, we don't do cardioversion. You need to do pacing. That's why later I explained about the transcutaneous pacing. Or you need to start isoprenaline or IV adrenaline infusion. If the patient presented with unstable tachyarrhythmia, can all patients be given synchronized shock despite considering type of arrhythmia and duration? Yes, if your patient is hemodynamically unstable tachyarrhythmia, it's a life-threatening situation. That patient is dying. If you are not properly managing this patient, yes, irrespective of arrhythmia, you need to cardiovert this patient. Any tachyarrhythmia treated with defibrillation, we defibrillate when patients are in cardiac arrest. Pulseless VT and ventricular fibrillation, we do defibrillation. Okay, I'll give you my email address. I think I'm taking other speakers' time. I'll stop at this point and I'm happy to answer your questions. And I will share my email address. It's difficult to send in this chat box my email address. I'll tell you, tvidanapathirana@yahoo.com. Yes, T Vidanapatirana, first letter from my name, T Vidanapatirana@yahoo.com. It's difficult to send into chat box. It's taking much time to type in this chat box. Anyway, I'm going to stop my presentation at this point. If anyone is having questions, please direct it to my email address. And I'll give my greetings and all the very best for your internships. Thank you very much.
Look, Tushar, they are having the tea break, so you can answer the questions until Dr. Dylan logs in, I think.
Okay, right. There's another question asked. So if SVT patient settled with verapamil, do we continue verapamil doses BD? No, we don't continue verapamil. Once rhythm is over, then SVT is settled, we discharge them from the emergency department and we direct them to cardiologist to assess. If we have electrophysiology, we direct them to electrophysiologist, otherwise to cardiologist to do echocardiogram and further studies. Before discharge, you need to confirm that your patient is not having any electrolyte abnormalities or any other precipitating, obvious precipitating factors which contribute to supraventricular tachycardia. What are the occasions we are consider asynchronous cardioversion? Asynchronous cardioversion means defibrillation. That is the only situation where cardiac arrest. That is pulseless VT and ventricular fibrillation. Again, the question is directed, sir, can you explain briefly how to become an emergency physician? Yes, you should have an idea which postgraduate stream you are going to selecting when you are starting your internship. You need to have basic idea on anatomy, physiology, physics and measurements, clinical pathology, and disaster management. These are the basic components assessed in selection exam. So you need to have 1 year post-intern period after completing your internship. After that, you need to apply for the postgraduate through Postgraduate Institute of Medicine for this selection examination. Any doctor practicing in Sri Lanka with Sri Lanka Medical Council registration, working in universities or Triforces can apply this exam. It's a very competitive exam, which consists of MCQ paper, short essay question, and OSCE. All these 3 components are considered in selecting candidates according to the merit order. Once you completed your internship, go through the PGIM website calendar display, exam dates. Sir, is EM rooted in internal medicine? No. Emergency medicine is a separate specialty and it's a separate path. It has a separate selection exam, 3 years registrar period, followed by 1 year senior registrar and minimum 1 year to maximum 2 years overseas training before you get board certification as a specialist. Is it okay to do pediatric and gyn-obs for internship to apply for emergency medicine? Yes. What differences it causes to the heart from synchronized cardioversion and elective question is not clear. Elective cardioversion. Question is not clear. Do you consider final MBBS merit order when selecting PG exams? No. When you are getting transfers, only your merit order considered. If same post, same batch, two people are competing for one post with same qualification, at that point merit order may consider, otherwise no. Can EM physician practice as a normal physicians? No, no. We are separate specialists. We are not physicians. We are completely different from conventional physicians. We are doing emergency department. We are working in accident and emergency department. I think I have answered most of the questions. Anyone interested in doing emergency medicine, you all are welcome to new specialty. When we are getting most of the transfers into our department, earlier it came as surgical opinion, BP opinion, like that. Now, when emergency physicians are there, we are the people giving opinions. If we need specialized opinion, only we talk to cardiologists or physicians or the surgeons. We managing all kind of patients. From birth to grave, that means neonate to geriatric patients. As far as you are competent in managing airway and emergencies, you can work in any department in your hospital, or if you have a plan to go overseas, you should have sound training and practice in managing emergencies. Someone has asked, what is the difference between cardioversion and pacing? Cardioversion, we are giving certain amount of pack of electricity straight away to heart within a very short period. But pacing, we are continuously giving electrical impulse through the thoracic wall, which is generated by the machine. That means you have seen that pacemakers, that pacemaker function is temporarily done by the defibrillator or the device available in the department with pacing facilities. Actually, someone has asked, sir, can we do postgraduate in medicine subjects? If we do intern in pediatrics, I am not sure. I cannot answer this question. You go to Postgraduate Institute of Medicine website. There they have clear, in each specialty, they have prospectus. That prospectus, they have advertised basic requirements for them to, for you to sit selection examinations. Somehow, finally, I managed to type my email address. Someone again asked, it is tvidhanapathiran@yahoo.com. Even if type, I cannot post it. Yeah, let's go. Sir, patient with a pacemaker, is it interfering when taking an ECG? It doesn't interfere, it gives pacemaker rhythm in ECG. It gives pacemaker rhythm in ECG. Okay, Dr. Roshan, I think I'll stop at this point.
Yeah, another 6 minutes if you like.
Let us ask Dr. Dylan to join with
yes, Dr. Dylan is here, we can start. So thank you very much, Dr. Tushara, for giving a profound insight of emergency medicine, and those who are interested to career pursuing in emergency medicine. I think in Sri Lanka, if the emergency medicine is very well, it is a very developing field, and a lot of young emergency physicians are currently working at very crucial areas in hospital wise. If they have work, if it's established well, our healthcare will come to very good status. Am I right, Dr. Shah?
Yes, exactly. And I would like to welcome everyone coming to District General Hospital Madara to my department to learn anytime. You can speak to me. We'll get more consultants in near future.
Yeah, I mean, all the admission goes to the external emergency care unit. If that's the I mean, if that is streamlined, the whole hospital patient management will be streamlined. So I think they are doing a marvelous and fabulous work. I mean, from the first contacts. So there are a lot of cases. I mean, mortality-wise, have been reduced due to they are taking over the emergency departments, and there are a lot of trainings also taken place, due simulations training in the provinces. I mean, currently there are less amount due to COVID, but a lot of things happening and sessions and all that. So you can. There's a website, I think yours, no, Dr. Tushara?
It has to be updated. Now these college works were a little bit delayed due to current COVID situations. Sooner we'll publish updated website.
So also they will be conducting APLS and NLS programs also, I think, no? Adult resuscitation. Yeah. Right. So those sort of trainings are there. So you can write to Dr. Tushara, get his insights and advice on all the things. And if you have any patient management issues also, you can discuss with him also. Right.
Most of the time, all the emergency physicians are happy to help you. Any sort of emergencies, any assistance, they are very friendly. Anytime you can speak to them and get any advice, any references, reading materials, or any guidance from them.
Yeah. Also, accident emergency manual is there on the health website under publications. So those who are interested can go to there and download and take use of it. Right. So next up is by lecture by Dr. Dylan Apasinghe. He's acting consultant at Teaching Hospital Koluboila on the topic of patients with shortness of breath. Another important topic. Over to you, Dr. Dylan. You have to unmute, Dr. Dylan. Dr. Dylan, are you there? And I think here's some small issue. Right.
Yeah,
coming up.
Can you hear me now?
Yes, loud and clear.
Roshan?
Yeah, can hear. Product may more triple is okay. Can you speak up? Hello, Dr. Dylan?
Right?
Yes. Hello.
Roshan, can you hear me now?
Yeah. Can hear. Can start.
Can you hear me?
Yes. Can start.
Can you hear me?
Loud and start.
Can you hear me? Can I continue? Can I continue? Can I continue?
Yeah, can you?
All right. I'm Dylan Abasingha, currently attached to Columbus Teaching Hospital, Kalaboila. My approach today, my topic is approach to emergency health. Roshan, can you hear me?
Can hear.
Roshan.
Yeah, can hear. ඒක පොඩ break up වෙනවා වගේ.
Is also there.
Yeah, can hear. Shall we start?
Now can you hear me?
Hello. But it didn't.
Prashant, can you hear me now? Prashant, can you hear me?
Yes, can you hear
Can you
yes.
hear me?
Yeah, we can see you also now at last.
All right, okay. Sure. All right. After emergency, so we managed to settle it down, right? Approach to shortness of breath in the emergency department. It's a very important topic as far as budding doctors are concerned. I'm Dylan Napsing, currently in emergency department at Kaluvori. This topic is very important for psychiatric disorder, so don't miss it out and manage according to like smart separate management plan. So I'm not giving it, but we'll try to give some salient points and try to catch it up. Right, shortness of breath. Very sorry about that. I think there are a lot of interruptions, right?
Yeah, DC shock क्या देने वाले थे?
Can you hear me now?
Yeah.
Yeah, I think so.
Dr. Dylan.
Everything is fine.
Yeah.
Sorry. Dyspnea,
Yeah.
hunger. Yes, it's very yeah.
Yeah, shall we do
Internet
this?
connection is unstable.
Yes, but will you join? Will you join from your phone and put the slide from the computer?
Okay, sure. That's a good idea, right?
Hands free corner में.
Can you hear me now?
Yes.
Prashant, can you hear me?
Yes, better.
All right. Sorry about the disturbance. Shortness of breath. All right. It's a reason for right. It's a reason for
Do you need to fix a hands free, Dr. Dylan?
Recording stopped.
You need to get a hands free, then it's easier. I think.
all right.
Yes. Slide ticket.
Right.
You need a hands free, otherwise echoing is there, Dr. Dylan.
Sorry.
You need to put a hands free, otherwise there's a echoing.
Yeah, exactly.
Hands free and oh, what you have to do with the computer, you stop all the mic and the speaker.
Now, all right.
Yes, okay, better.
All right. Okay. I can continue.
You need the slides.
Sorry.
Slides share kara.
Right. Shortness of breath. Now it starts, right? Okay. It's a later means air hunger. It's a subjective symptom of breathlessness, as I said earlier. It's very unpleasant subjective sensation of abdominal respiration. Normal in heavy exertion, but with it's pathological if it occurs in unexpected situations, like when you are in a sitting position, sleeping position. If you develop shortness of breath, that is abnormal. Right. So reasons for this shortness of breath. Can you remember your good old days physiology? So basically, rearrangement in oxygenation as well as acidemia, which lead to breathing discomfort. However, it's a complex phenomena. You know that it's very complex situations. It's difficult to understand. Like in acidemia, stimulate your brain center, and as a result of that, you can get the result of simulation of heavy stimulation of mechanoreceptors throughout from upper airway to chest wall. Right. What are the causes for dyspnea? The first one is cardiac causes. Then the second one is pulmonary causes. The third one is mixed cardiopulmonary. Fourth one is non-cardiopulmonary causes. So cardiac causes wise, arrhythmias, then myocardial infarction, ischemia, cardiomyopathy. Pulmonary wise, it's asthma, pericardial effusion, pneumothorax, COPD, pneumonia. You can get it. The mixed cardiac pulmonary causes are obstruction, mainly obstruction, and cardiopulmonary disease, mainly congenital cardiopulmonary disease. Non-cardiopulmonary causes are very important to understand. The first one is DKA, and the second one is sepsis. Apart from abdominal sepsis, meningitis, It may be meningitis, then you can get necrotizing fasciitis and psychogenic problems. Then recognition is very important. So in our department, emergency department, you know that it's MACTA. MACTA means airway, breathing, circulation, disability, and exposure. It's very important to go through this system and find out the emergency as well. It's airway, breathing, circulation, and disability. It's very important, and exposure. Right. What are the red flags in shortness of breath? History of chest pain and faintishness, it's suggestive of myocardial infarction. So you have to go for that immediate. Then history of congenital heart disease, congenital or congestive heart disease, then congenital lung disease. It's very important. History of trauma, surgery. Yes, shortness of breath may associate with pneumothorax, hemothorax, and things like that. Past history of surgery, maybe sepsis, maybe pneumothorax, maybe pneumonia. Yes. Ongoing illness like hypertension, diabetes, bronchial asthma, COPD. You know that they are very prone to get shortness of breath according to their illnesses. Examination-wise, secretions, obstruction, swelling will obstruct your upper airway. It's very important. Grasping breathing, so pre-terminal. So you have to do something immediately, otherwise patient may die. Bradycardia, apnea, then respiratory distress using accessory muscles of respiration, tachycardia, and restlessness are the features of respiratory distress. Shock, bradycardia, and arrhythmias suggestive of pre-terminal conditions. Fever, cyanosis, pallor, rashes, sometimes suggestive of septicemia. So basically, you have to do something for these patients immediately. Otherwise, it's very, it's very time limiting factors, and then patient may die. All right. Approach to dyspnea. First, what you have to do is check whether patient is responding or not. If patient is not responding, you have to start CPR. If patient is responding, not responding, then you have to start CPR, check his central pulses and start CPR. If not responding, straight away you got to start the CPR, right? Then the primary survey if the patient is traumatic, otherwise you can go according to the airway, breathing, circulation wise. Airway wise, suck out the secretion and prop up the patient and start oxygen. Then connect it to the monitor, pulse oximetry, and check the saturation. Then circulation wise, check blood pressure and pulse, everything. And you can cannulate the patient and take some blood for, a VPG, APG, then troponin, full blood counts, and electrolytes. Check the glucose in disability and DCS as well. Then temperature-wise, very important to check the temperature these days. Maybe COVID pneumonia, maybe sepsis, maybe dengue. So check the temperature, very important. The most important thing is hypotension is also, hypothermia is also feature of sepsis. Then investigation wise, basic investigation, ECG, X-rays, bedside ultrasound scan, IV antibiotics, stat doses of normal saline antibiotics, yes. Nebulization and blood transfusions are very important for these patients. Then if it is a trauma patient, then the secondary survey, this position is very important. So I'm very sorry. I know that there is interruptions and you can't see the slides presentation. So I will send the slides later. But just have a look on slides here and there. Then listen to this lecture. Right? Sorry about that. Because I'm in the hospital at the moment, so this place is not used to me. But some more I have to do it properly. Right. Investigations wise, very important investigations wise, blood investigations, airway breathing, ABG, VBG is very important. Then the full blood count, CRP, blood sugar, troponin. Chest X-ray is very important in patient with shortness of breath. You have to exclude pneumonia, pneumothorax and things like that. Then the urine is very important. SCG levels and albumin levels are very important. Bedside investigations like ultrasound scan, bedside echo. You know, it's very important to improve your knowledge on ultrasound scan and skills of your ultrasound scan, because it's very important at the hospital bedside to do the search and investigation. The sensitivity is very high, specificity is very high in ultrasound scan at bedside. Right. First topic is asthma. I don't give much details about asthma, but it's basic the stuff. You have to improve those things. Asthma is a reversible bronchoconstriction, as you all know. It's a reversible bronchoconstriction due to inflammation. It's air block between the upper airway, most likely lower airway. Alveoli may be collapsed because of these bronchoconstrictions and reduce air into the alveoli. The clinical features like cyanosis, tachypnea, sweating is there. There may be intercostal, subcostal recession, increased respiratory rate, and apart from that, patient may have tachycardia, low saturation. There are a few things I want to emphasize. There may be patients who may present with silent chest. They are pre-terminal. So you have to do something definitely, otherwise the patient may die. Then low blood pressure may be pre-terminal. So in that situation, bradycardia, low blood pressure may be very important. And in that situation, you have to treat the patient properly. Right. So then the next topic is very important, the management. So bronchodilators are for symptomatic treatment. Because this is an anti-inflammatory situation, so you have to treat the patient. Inflammation means you need to give steroid for these patients, right? So very important to give anti-inflammation to those patients. So it will take at least about 4 hours. That's the problem. That's why we give bronchodilators. So bronchodilators are salbutamol, ipratropium. Then you can give sometimes sulfate. Those are the bronchodilators we are talking about. Anti-inflammatory wise, you can give hydrocortisone, oral prednisolone. Treat for underlying infection if there is anything like you can treat it as antibiotic. Education is very important, and then you have to decide this position. After about 5 hours of resuscitation, then you can give you can treat with after treating 4 hours, then you can disposition the patient either ICU or the board. Right. Next topic is COPD. The only difference is the exertional breathlessness, chronic cough, people with regular sputum production and sneezing. This is not a reversible cause, but reversible problem. So, but the thing is, even though this is not reversible, sometimes you with your basic treatment for asthma can respond, right? They have marked dyspnea, tachypnea, first lip breathing, use of accessory muscles, acute confusional state, new onset peripheral edema. Peripheral edema may be due to 2 reasons. The first one is sputum production will reduce your albumin level. The other one is heart failure. Acute confusion may be due to carbon dioxide retention. So it's very important to understand the situation at the moment. So we follow BTS guidelines. So oxygen, don't give too much of oxygen, that can aggravate the situation. Try to keep saturation around 88 to 92. That is more than enough for these patients. Try bronchodilators, corticosteroid, as I earlier mentioned, then antibiotics. So they can have atypical bacteria. So you have to start something like erythromycin and oral doxycycline for these patients. So it's very important. They can have treatment. I mean, they can respond to bronchodilators and corticosteroid. Otherwise, if there is any carbon dioxide retention and severe hypoxic level, you have to go for the BiPAPs or non-invasive ventilation. Right. This topic is very rare. Pulmonary embolism, pulmonary edema is a very common topic, and we treat, I think, not in a proper way. Like, even for pulmonary edema, we used to give salbutamol, nebulization, hydrocortisone nebulization. So I will try to explain you that, that can aggravate the pulmonary edema. So that's why I want you to start the proper treatment after diagnosing the situation. So pulmonary edema can't contract well due to reduced contractility. So you can again remember your Stalin forces, Stalin curve, and everything in your good old days physiology. It can be due to ischemic heart disease, arrhythmias, hypertension, cardiomyopathy, etc. The cardiac oxygen demand is increased. That's the problem. Air can't cross the airborne. So it seeps into the alveoli and surfactant gets diluted, right? So that's what happened in this situation. So caused by cardiac and vascular dearrangement, it's a vicious cycle. So the most important thing is very well. Right. It's caused by cardiac and vascular dearrangement, and it's a vicious cycle. So you have to treat the patient accordingly. Right. So how do you manage the patient? So prop up the patient, oxygen, keep saturation about 92, 95 level, less than 95, because oxygen will dilate your pulmonary vessel. So that can again reversely act on your lungs. Then the next thing is the GTN infusion is very important. GTN infusion is very good medication for this situation. It can suddenly dilate your venous system and reduce your preload and upload. Apart from that, if you want to stop the action, it will take about 2 to 3 minutes. So it's very important to start GTN infusion. The problem with GTN infusion is if blood pressure is less than 100 or even 100, you can't start. The other thing is it has a side effect called reflex tachycardia. So that can aggravate the heart failure, but it is definitely reduce your preload and upload. That's a very good drug. Then you can go for a non-invasive ventilation. So if it is a type 1 respiratory failure, that is hypoxia, then you can start CPAP. There is a carbon dioxide retention with type 2 respiratory failure, then go for a BiPAP. I just want to emphasize about furosemide at the moment. Furosemide is a good medication, but not in the initial stage. So if you give furosemide, it will take about 20 minutes to get active. So because of that, we don't start furosemide immediately. The drug of choice is GTN and CPAP, and fluid restriction is very important. The most important thing is here is treat for the cause. The heart failure may be due to ischemic heart disease. In that situation, you have to start thrombolysis. Arrhythmias, yes, as Tushara mentioned in the last lecture, you have to resuscitate the patient with arrhythmia cardioversions or electrical or chemical cardioversion. Then antihypertensive for patients with hypertensive pulmonary edema. Then inotrope for carditis, antibiotics. Then referral and dispositions is very important in this situation. Right. Then the third is this one is pneumonia. Pneumonia is infection in the lower airway. You can see have consolidation and fluid-filled alveoli. That is the problem we have. So we have to treat patients immediately, and treatment-wise, antibiotics is very important. You can remember your half an hour bundle, 1 hour bundle, sorry, and 6 hour bundles. Twice you have to treat the patient. The antibiotics, bacterial, symptomatic treatments like paracetamol, bronchodilators, and non-invasive ventilations again. If it is a type 1 respiratory failure, you can start CPAP. For type 2 respiratory failure, you can start BiPAP. These days, very important to understand the COVID situation. Any patients who comes with a history of shortness of breath,
and having fever, sore throat, that sort of features, you have to suspect COVID. In this situation, it's very important to treat patients early, right? So imagine saturation is around 90s. If you start your treatment earlier, that would be better. That can survive the patient. Otherwise, patient may die. Most of the time, elderly people who comes at the last stage. So in this that situation, it's very difficult to treat them. So that's why these increase deaths at the moment. So it's very important to understand the COVID situation and dengue as well. So it's very difficult to diagnose, but you have to initially start fever, sore throat, shortness of breath, more suggestive of COVID rather than dengue at the moment. Right, as I said, you have to follow the sepsis bundle, antibiotics, fluids, vasopressors, and symptomatic treatments again. Right. Next topic is very important topics. That's why I said earlier, you have to increase your skills as well as knowledge in this situation. Pneumo and pneumothorax. Stuff gets between the parietal and visceral, in between the skin and the chest ribs. So it's very important, to diagnose the situations. So there are three fatal conditions. The first one is tension pneumothorax, the second one is open pneumothorax, and third one is massive pneumothorax. Tension pneumothorax can be due to medical or surgical. Surgical means traumatic. So traumatic situation, it's very easy to treat. Your patient, suspected patient with pneumothorax, what you have to do is just put your finger, need to do a thoracotomy, finger thoracotomy. So it's both intercostal space. Just put your, cut the area and put your finger and raise the pressure of that. But open pneumothorax is a separate story. Like open pneumothorax, there is a valve effect. So what are you going to do is you stop the valve effects by applying a three side plaster. So there is no more valvular effects. Then the hemothorax and pneumothorax, later you can put IC tube and for the standard long-term management. But medical pneumothorax, you don't do the finger thoracotomy. What you can do is you just put a white bore needle at the second intercostal place at the mid-clavicular line. So that is what you have to manage the pneumothorax medically. But traumatic wise, just put your fingers, release the pressure. All right. Then the next topic is pulmonary embolism. It's a very rare topic in Sri Lanka. Oh, we don't diagnose it properly. I don't know. It's a blood clot in the pulmonary circulation, often arterial or most in the pulmonary artery and the venous system in the legs. So hypoxia, tachycardia, tachypnea, sometimes periodic type chest pain. So you can get long travels, fast history of venous embolism. So those are the things. So then you have to go, if it is we manage medically. There are three types: mild, moderate, and severe. Severe, straight away you have to start thrombolytics. Mild and moderate, you have to go according to the well scope. We have a well scope. It's a standard protocol. And if it is positive, then you have to go for a Herc score, then go for a CT scan or ultrasound scan. So diagnosis is according to the CT scan, and if there's a pulmonary CTPA, pulmonary arteriogram, and see whether there is a thrombus. Then if there is a thrombus, you can treat with anticoagulation. And oxygen therapy is very important because they are hypoxic. TPA and enoxaparin, heparin, you can use for these patients. Right. This is a non-cardiac and pulmonary situation, diabetic ketoacidosis. It's very important, very under diagnosed and undertreated situations. Tachypnea often without air hunger. Polyuria, polydipsia, loss of weight, and dehydration are the other features. So how do you manage? What are the salient points in managing diabetic ketoacidosis? There are few. The first one is you have to treat for these patients acidosis. That is the fatal condition. Then you have to treat the patient's positive factors, so underlying factors for develop this diabetic ketoacidosis. Third one is you have to prevent from the complications. So hyperglycemia is not the most here. It's the most important thing is acidosis. Acidosis is due to mainly ketone body production. So you start uh, you start insulin for these patients. So how do you diagnose these patients? They are diagnosed patients. Sometimes they are diagnosed patients with the patient with diabetes. Or this may be the first episode when their blood sugar level is more than 11 millimoles per liter, that is 200 milligrams per kg. Then acidosis, metabolic acidosis, pH is less than 7.3 or bicarbonate less than 15. Then the other features like ketone bodies are present. Right, stop ketone productions. As I said, you have to start insulin. Treat for underlying causes like infection, ischemic heart disease, and diabetes. Prevent for complications like electrolyte imbalance and cerebral edema. The most important electrolyte imbalance is hypokalemia. So we have to be very careful when you start insulin and dextrose for these patients. Monitoring is very, very important. Don't stop insulin if you have, if the sugar level is low, but the most important thing is stop insulin when the glucose level is less than 200, but pH is greater than, should be pH is greater than 7.3 and the bicarbonate is more than 18. So this is the very important situation. Even though glucose level is less than 200, if pH and bicarbonate level are high, you have to start 5% dextrose and continue insulin. That is the most important thing to stop acidosis. Right. Other situations are you have to know these things: the carbon monoxide poisoning and cyanide poisoning. Carbon monoxide poisoning. The most important thing is you have to start uh, oxygen, maybe hyperbaric oxygen, and cyanide poisoning. I don't think you can do much for these patients because probably on the way patient may die. This is the last topic I want to emphasize: the anxiety, panic disorders, phobias, delusion, withdrawals, and hallucinations. So psychogenic is very important topic. Don't say that this patient is having some psychiatric problem. Don't try to sort of on the patient. So just go and have a look on that patient because sometimes they may have a withdrawal features like very high blood pressure, tachycardia, and sweating and everything. So after few minutes, patient may die because of this problem. So hallucinations are very important. Patient is having hallucination at the moment. So as a result of that, they can have sort of a tachycardia, hypertension, sweating, and things. So that may be the first presentation of his, psychogenic, psychiatric illness like schizophrenia or bipolar disorder. So it's very important to treat and diagnose patient at the emergency department. Right. Very sorry about these slides, but tell me about your questions if there is any. Any questions? Right. The first question, I thought you are not with me, right? Anyway, first question was tension pneumothorax, where should we insert the needle? So tension pneumothorax, as I said, there are two things. The first one is, if it is, imagine following a trauma situation, you put your finger, that is called finger thoracotomy. Finger thoracotomy, you put your finger in the fourth intercostal space. You know that safe triangle, anterior axial line, mid axial line, and fifth intercostal space. So you put your finger through fourth intercostal space. But in medical pneumothorax, like spontaneous pneumothorax, you put your finger, needle, it should be a white bore needle, at the mid-axial line in the second intercostal space. So that is the most important thing, is the second intercostal space at mid-clavicular line, right? So after that, once the patient is stabilized, then you have to put a IC tube. IC tube is again in the fourth intercostal space. You know that it's a very important area. Because there are a lot of nerves and vessels are there. That's why we use this safe triangle, right? So it's a very important skill to develop as a internal HO house officer or in junior doctors. Yeah. The second question. Second question. Yeah. How can we differentiate shortness of breath from the fatigue in COVID situation? It's difficult, right? So fatigue, the shortness of breath is the difficulty in breathing, and it may be due to hypoxia and the acidosis, as I said. The fatigue is also the same. Like, if you can't, if you can't breathe properly because of the problem with your respiratory muscles, so you can get shortness of breath as well as fatigue. But I don't think you have to recognize that as well. But treat as shortness of breath. Check the blood pressure, check the saturation, and check the lung features and treat accordingly. It may be due to pneumonitis rather than pneumonia in COVID situation, but then you have to start steroid and other treatment for this thing. Okay, all right. Any questions?
Yeah, Dr. Dilan, there are some questions on the chat box. Are you there?
Yeah. Can you read me?
Yeah. How can we exclude psychogenic causes from medical ones? I don't know which one.
Yeah. The most important thing in psychogenic ones are the patient doesn't have any tachycardia, even though patient has a high respiratory rate. Doesn't have sweating, tachycardia, hypertension. But if you take organic causes like schizophrenia, hallucinations, alcohol withdrawal, their blood pressure, respiratory rate, and symptomatic sympathetic symptoms like sweating, shortness of breath are there. So their saturation anyway is okay. If you do a ABG, they have a good psychogenic patient, they have good oxygenation, but other people they don't have. So basically, it's a clinical experience. But my point is like don't ignore them saying that they are psychogenic and things like that. But because psychogenic people, they have a high tendency to get alcohol, heroin, and things like that. So then that will be a problem for them. So don't don't ignore them and treat them. So then you can check the blood pressure and everything. All right. Then the pneumothorax. There are other questions.
It's a patient home-based COVID patient develop a SOB at home.
Yeah.
Until hospital, what are the interventions?
Unfortunately, for transport system, we don't have that much of developed transport system, even though the 1990, they have oxygen. So what you can do is just start oxygen. Apart from that, I don't think we have the other facilities like CPAP or anything else. Even we can't do sort of a VBG on the way. But the most important thing is patients develop shortness of breath and check their saturation if possible, and send the patients to the nearest hospital as soon as possible. The most important thing is home-based treatments. They are not very high-risk patients like elderly patients or any other comorbidities like diabetes, hypertensive patients. So they are less than 65. I think they are cut-off age. So they don't have comorbidities and the for this high-risk situation. So the most important thing is oxygen and send to the hospital as soon as possible. Right. Anything else?
Right. The next question is TPA, how to use?
What is it?
TPA, how to use?
TB. I mean, nothing to worry at the moment. So anyone who comes to the department or emergency or ward, you can learn it. It's depend on. There are two factors I want to emphasize. TPA. It's depend on your clinical situation. Like there is contraindications, you can't stop, you can't use it, and we give it according to the patient's body weight. So that's what you want to know at the moment. Then it's a different story. We give it as IV medication, sometime infusion, sometime IV bolus. So it's a thrombolytic agents, TPA thrombolytic agents, give according to body weight after excluding contraindications. Any questions, Roshan?
I think that's all. Okay, what are the causes for medical pneumothorax?
It's not basically medical pneumothorax. It's basically due to medical pneumothorax, like not so traumatic pneumothorax. Medical pneumothorax can be due to you have autoimmune diseases like Marfan syndrome. You can get it. Autoimmune disease like SLE, you can get spontaneous pneumothorax. Apart from that, Marfan spontaneous pneumothorax, and those are the common situations I can remember at the moment. Yeah.
Please repeat the new site of needle thoracentesis.
Sorry, can you remember? Can you repeat it?
Yeah, new site for needle thoracentesis.
That's as I told earlier, like finger thoracotomy, you put your finger in at the fourth intercostal space where you put your IC tube, right? White bore needle you put at the second intercostal space at the mid clavicular line. Did you understand that? Or just want to emphasize more? Right. Any questions?
I think we thank you very much, Dr. Dilan Appasinghe, consultant emergency physician at CSTH Kalabovila. Thank you very much. Go to the next lecture by Asanga Miguel Heva on management of shock. Dr. Asanga, are you there?
Yeah, I'm here.
Okay, we can start.
All right, so can you all see the screen presentation?
Yeah, you can see. You can start.
Yeah, okay. Right, so I'll be doing a basic lecture on shock. So before I start the presentation, let me introduce myself. I'm Assam Chemical here, so I'm working as a consultant physician in Karapi Hospital, and I also have some background in retrieval medicine, and also working as a supervisor and coordinator for 190 on-call doctors. So we will be talking about shock today, which will be running for the next 40 minutes. Basically, so what I want all of you to know, now you'll be starting your careers as interns. So what I want to highlight in this lecture is to identify the shock. So management, once you identify the management will happen, but the most important thing, you need to identify them. So more you get late with identifying the shock, then the things could get really complicated and the patient could die, right? Right, so this would be the objectives which I'm covering today. So I would be defining the shock and briefly outline the classification of the shock and discuss never to miss things in shock. And then we'll be discussing a few cases regarding common presentation of shock with different categories. So if you all have any questions in between the lecture, you can type down and have it in the chat box. So I will be answering the question after the end of my lecture. Give me 1 sec. Give me 1 minute. I just need to update my screen. So I'm having few other screen also happening. So give me 1 minute till I get this sorted out. Right. Sorry for that. Yeah. Can you all see the screen?
Yes, can see.
Yeah. All right. So what is shock? So basically, I would say it simply in simple words, or shock would be something which could lead to death, right? So if you don't identify them, the patient can die. So in medical terms, the shock, I can say shock, is something where you have a lack of oxygen to the tissue level. So there's a reduced perfusion to the tissues. So that's the definition of the shock. And when you classify the shock, So if you could memorize this diagram, so then you would be able to go through the different types of causes. So it's basically, you will be looking at the pump, the tank, and then the fluid. So if you have any problem with these structures, the patient can go into shock. So what happened here now, if you look at the normal mechanism where the tissue gets blood, so the heart has to work properly, and there would be a tubing system which connects the heart and get the blood to the tissues. So you have to have tubing system, which is the arterial and venous system, and you have to have blood. So blood contains mainly water. So these are the few things you need to think of if someone coming with shock. So it's your heart, and then you have the tubings, and then you have the blood, which also contains water as the majority.
Sorry to interrupt. So we can't see your screen.
You can't see?
Yes, sir.
Can you see?
Yes, sir.
Yeah. So this is a basic diagram which you need to know. So where you, I would go again briefly. So you can see the heart, and then you have the tubing systems, and then you have the blood inside the tubing systems. So if you have any problem with one of these structure, one or more of the structure, the patient can go into a shock stage. So basically reduce blood supply to tissues. So what are the common types of shock? Number one is cardiogenic shock. So where the pump doesn't work. So it could be the left side of the heart, which is the left ventricular problem, or it could be the right side of the heart, which is the right ventricular, or it could be both. Number two is the hypovolemic stage, where you have the normal working heart. The heart works normally, but you don't have enough blood inside the pump. So this could be due to bleeding, or this could be due to significant hypovolemia, something like acute severe gastroenteritis, which leads a lot of losing of the fluid status. And number three shock is called obstructive shock. So here you have normal working heart. So heart contractions are good, and you have the normal amount of blood volume inside there, but there's an obstruction to the flow. So this could be right side of the heart, which is commonly the pulmonary embolism. So the venous return will be blocked to the heart. Number two would be blockage of the arterial system, so aortic problem, or a pneumothorax, which again causing high intrathoracic pressure, which again blocks the aortic input. Or this could be a increased pressure outside the heart, which is a pericardial tamponade. So all these causes are called obstructive shock. And number three is called distributive shock, where in the distributive shock, you have normal working heart, you have normal amount of blood, and there's no obstruction to the outflow, but so there's a dilatation of the arterial system. So this is called distributive shock. So there's a compensatory reduction of blood volume due to the arterial venous dilatation. So what are the common causes? The number one killer of shock is sepsis, where you get a dilatation of the blood vessels, which cause relative hypovolemia, or something like Addison disease, where the same thing happens, where when you don't have enough hydrocortisone, the cortisone in your blood, so the normal tonicity of the blood vessel will not be maintained. Again, it will go into dilated state. Or this could be a neurogenic shock, where you have high cervical spine, C-spine injury, where the the blood vessel will be dilated. Right? So these are things, these are the causes you need to know, right? So recognition of shock, basically history is important, and then you will be going with the vital parameters, and then you will be looking at the end organ dysfunction. So these are things, right? But the main question, how do we identify early stage of shock? So how do we identify early stage of shock without delaying a critical diagnosis, which can lead to delay in the management? So we all know history is important. So if you take a good history, so you can get a lot of information, which I'm not going into details. But having said that, now in some of the patient, you might not be able to take much history because the patient comes in a real critical stage. So where you will not be having enough history because there will be no bystander sometimes, and sometimes you don't have enough time because you will be working with the patient to keep him alive, right? So history is important, but sometimes you might not get a time or a proper history depending on the circumstance. So then I'm going to go.
Slide, Dr. Asanga, slides are not moving, I think. Still,
So,
Martin Luther King is there.
Yeah. So I didn't go. So I'm still with the Martin Luther.
Fine. Okay, fine.
Yeah. Right. So now I'm going to most important things, right? So I'll go now. These are the things you should remember in your career when you start. So how to pick the shock stage, right? So one of the important parameter is the blood pressure and the heart rate. So if you see extreme bradycardia, always think whether you are dealing with shock. So if the heart rate goes below 40, most of the time, the patient will not be able to give enough cardiac output, unless if this is a young athlete. So always think about the heart rate. And also for this, the same matter, if someone gets really tachycardic, if the heart rate goes above 170, 180, in cases like supraventricular tachycardia and ventricular tachycardia, again, the heart will be contracted to a stage where there will be no adequate contraction, effective contraction to give enough cardiac output to the tissues. Right? So always remember the extremely bradycardic and extremely tachycardic, whether you are dealing with a shock stage. And then one of the key thing, which is called shock index, where you divide the heart rate by the systolic blood pressure. So if the shock index more than, some say 0.8, some say more than 1. So that's extremely suggestive, the patient in a shock stage. So in simple stage, if the heart rate goes higher and systolic blood pressure drops down, so then you have to think whether you are dealing with the shock stage. Number 2, urine output. So urine output is a really important parameter. You can ask from in the history whether the patient had produced enough urine output. If not, once you catheterize the patient, have a look at the urine color. So if you, now on the right, on the left of the screen, you can see extremely concentrated urine, low volume. And on the left lower corner, the right lower corner, you can see a good non-concentrated urine. So you can identify, once you put the catheter, if you see the very dark color urine, then again, you need to think whether this patient getting enough end organ perfusion. This means the kidneys are not perfusing. So this is a thing where you can catch shock stage early. Number 3, the skin. So if you look at the skin, once you feel the skin, if the skin is like cold, clammy, think whether you're dealing with shock. So for example, if the patient coming with severe chest pain and ECG showing anterior ST elevation MR, and when you feel the skin, it's very cold and clammy up to the knees and elbow, definitely you need to worry whether the heart is contracting enough to give the perfusion to the skin. For the same matter, if you get a fever patient with dengue, you suspected dengue, 5 days history of fever, and the platelet count of 80,000, and then when you feel the peripheries of the child, and again up to the knee and elbows, the skin is very cold with reduced capillary fill time, then again you need to think whether you are dealing with shock, right? And in some instance, you can have warm bound impulse in septic shock, because as I mentioned, it's a vasodilated state, distributive kind of shock, where you can feel very warm and bound impulses at the early stage of the septic shock. And in some instances, you can see low blood pressure with rash urticaria, that's an anaphylaxis or severe allergic reaction. And number 4 is really important thing. If you look at this picture, this is called mottling. So this is due to extreme vasoconstriction at the skin tissue levels. So this is suggestive of significant production of vasoconstrictors at the endogenous vasoconstriction production, which again suggestive of late stage of shock. So if you see this skin mottling, always be worried. But vice versa, if you don't see skin mottling, you can't exclude whether this patient is not having a shock, right? So, but if you see this, it's very worrying. So I explained few important parameters where you would be eliciting if you think of shock. Number 1, I mentioned about the heart rate and blood pressure, and also touch upon the shock index. Number 2, the urine output, and number 3, the skin changes in various kind of shock. And this is again really important, the mentation, the GCS, level of GCS. And we have seen again and again, and you will see once you go to the ward. So the patient coming with a fever and saturation may be margin 90 and extremely agitated. And then what we do, we tie the patient up and then shout at the patient and say, now, but you have to always think whether this patient agitated for reason being not getting enough blood to the brain. So always you have to be thankful if someone is having reduced GCS, agitated. Always that could be a worrying sign of a shock, because your brain, the patient brain must not be getting enough blood. Right? So mentation, again, really important. So these are the clinical parameters you can go. Once you have done that, then you can go to the lab value. So labs, I know we all know the basic labs we will be doing: full blood count, the blood cultures, CRP, serum electrolyte, and everything. But most important thing I would like to highlight is the lactate, because lactate is a production of anaerobic metabolism when the tissue doesn't get enough oxygen. So which is due to cortical activation. So if you see any patient coming with high lactate, always you need to think whether you are dealing with a shock. So you can now, if you are thinking about shock stage in a patient, do a VBG or an arterial blood gas and assess the lactate. So if the lactate is high, more than 2, so then always there's a sign of tissue level anaerobic metabolism. That's again confirm the shock. But again, you need to be mindful. There are some conditions where the lactate will be anyway elevated. For example, if you have a liver failure, your lactate will not be converted back to the glucose at the liver, which is the normal cycle. Then you will be having high lactate. So liver failure, you will be anyway looking at a high lactate value. And any patient like excessive exercise or like status convulsion, then you would have high lactate because of the tissue action. But again, this is not a shock stage. Once the fits resolve, or once the exercise resolve, exercise completed, then the lactate will be clear. But I will be talking more in a stage where there's a patient has like permanent reduction to the blood volume, blood supply to the tissues, right? So most important lab would be lactate. And then value of ultrasound scan, then I'm not going in detail because you will be learning this once you start your internship and more once you go on through internship. The ultrasound scan is really important, and we can diagnose many conditions within few minutes. So we all have the ultrasound scans in the emergency department. So anytime we can diagnose, basically you can do, like, for example, you can do a quick scan of the heart and assess the contraction and check the pericardial effusions. And then you can check the lungs for pneumothorax, and you can check whether there's any like free fluid like hemothorax, abdominal bleeding, ruptured ectopic pregnancy. And then you can check whether there's any signs of pulmonary embolism. And you can check the aorta for dissection or aneurysm rupture. So basically, you can see, like, you can do a checklist of most of all, like, not to miss causes of shock in few minutes. So one of the protocol we use in the emergency department, which is called RUSH protocol. So anyone who would be interested, go and read about that. But remember, ultrasound scan is one of the change over the last decade where it's been really useful in the emergency department in a case of undifferentiated shock. Right. So before we move to the causes, now let me summarize again. Now, shock might be coming with atypical presentation. Right? You will not see the typical low blood pressure, tachycardic, low volume pulse, reduced GCS, and reduced urine output patient. So you might see one or more of these parameters alteration. So it's your responsibility as a house officer once you start to identify these patients early, right? So always, even you see one or more parameters altered, just like be thoroughful and get your seniors to assess this patient, right? So it's better to overdiagnose shock rather than underdiagnose shock at the late stage, right? Because once it's gone to a level, to a decompensate stage, then it will be really difficult to reverse and treat the patient, right? Right. So now, so I would like one by one to ask, like, so one of the volunteers can pick this case, and can you, like, now I would like to see an answer, right? So number one case, you have a 26-year-old woman who is an athlete. So basically present with collapse, abdominal pain and shoulder tip pain. So what is the likely diagnosis? And her pulse rate is 100, blood pressure 100 of systolics, and she's pale and anxious. So does she have shock? So one of the pre-intern can answer. So does this patient has shock, and what's your diagnosis? Dinushi? So anyone? I would like to have an answer. Just go, give it a try. So does this patient have shock or not? Right. So if you look at this case, there are a few things you need to remember. Now, this is a young woman, athlete. So you would expect this patient to be bradycardic. If you look at most of the young athletes, they will be running bradycardic because their heart is trained in a way to have pump good cardiac output with a low heart rate. Right? So this heart rate of 100 is extremely concerning for this patient, although the blood pressure is maintained at 100, right? And also she's pale. That means she's not getting enough blood to the skin. So this is a worrying patient, which like to have with this being a female and abdominal pain and collapse. So this is unless proven otherwise, it's a ruptured ectopic pregnancy. But I want to highlight the fact that now you would not, don't wait till the heart rate goes to 120, 130 or the blood pressure to be crashed in this patient. So this patient has to be managed immediately because the young patient will compensate till to the late stage. So I have seen patients where they suddenly go into cardiac arrest without dropping the blood pressure, right? Because they have good sympathetic system where they can compensate, but the compensation will stop in a time where you need to treat this patient immediately before you stop it, before the patient stop it, right? So here, athlete, young, pulse rate 100, pale, it's all our worry. So always try to pick this patient. So this is a hemorrhagic shock. So basically hypovolemic shock due to the bleeding. And again, now this is the classical teaching you had during the medical student, which I found extremely unreliable, right? So don't go. So it's, I mean, for the exams, you can remember this, the classification, but I have seen so many variations, especially in the trauma and bleeding in young patients where they will not drop the blood pressure. So the tachycardia being low volume will be one of the key to identify them early. So how do you manage shock in bleeding? So basically, you give fluid back. Why they have dropped the blood pressure? Because they have been bleeding. So you have to replace the fluid. Basically the fluid has to be blood, nothing else, right? So remember, if someone is bleeding, maybe in a trauma, maybe intra-abdominal bleeding, something like due to ectopic pregnancy, what the patient needs is blood, nothing else. You can give maybe 500 to 1 liter of saline, but never delay the blood. Just get blood and give it, because if you give like loads of saline, like 2-3 liters of saline, what you're doing is a dilution of the blood products. Basically, you are not going to win if you don't give enough blood, right? Remember, always look for early stages of hemorrhagic shock and consider giving blood early. In my trauma patient, I usually give, in young trauma patient, I usually give blood if the patient is tachycardic and blood pressure is like less than 90. Systolic blood pressure less than 90, I would probably give blood. So these are the common management pitfalls you need to know. So don't ever underestimate blood loss. And don't rely on one parameter alone in signs of shock. So we discussed the blood pressure being normal in young patient. And for that matter, you could have drop in blood pressure with normal pulse rate in adult patient, like especially in elderly patient. Why is that? Because they might not have the normal sympathetic output because of the disease stage, and most of these patients would be on a lot of medication, especially calcium channel and beta blockers, where they will not mount the tachycardia. So always think. So if you have a patient coming with hematemesis, with liver failure, who is on beta blocker, heart rate of 70, 80 doesn't mean anything. So you have to check the volume of the heart rate, because they will not have the classical tachycardia because of the beta blockage, right? So always go through with the patient circumstance, right? So elderly and young patient are two caveats where you need to remember. And so what I've seen, we don't give enough fluid, especially blood, in trauma patient. That might lead to significant level of comorbidities and mortality. So always think early blood and how much of blood to give. So number 2, so 66-year-old man coming with central crushing chest pain, and an ECG shows anterior ST elevation MR. And his pulse rate is 120, systolic blood pressure is 80, and he's pale and clammy and agitated. Now this is, like, no doubt this is a shock. So you have all the criteria to fulfill. tachycardic, low blood pressure, skin changes, and mentation reduction. So this is a classical shock. Why the patient is in shock stage? That's due to production of change in the pump being not being able to work properly. So basically, patient having a ST elevation myocardial infarction, the heart is going down. So it's a STEMI, and this patient is in cardiogenic shock. So how would you treat? So you have to reverse the infarction. Basically, you need to either do the lyse clot by giving thrombolytics, or this patient needs to go to a coronary angioplasty immediately. So basically has to go to cath lab immediately. But remember, again, you have to identify these patients, right? And there are few causes of cardiogenic shock, what I have explained is the STEMI, because due to the left ventricular muscle damage, but the damage should be left or the right, or the arrhythmias and mechanical problems. So mechanical valvular problems, right? So these are the common causes of cardiogenic shock. And in myocardial infarction, you might have one or more cases of reason to have drop in blood pressure or the shock stage. For example, if you have inferior STEMI, you would have a shock stage due to right ventricular failure because of the right ventricular infarction. So these are things you need to remember in case of cardiogenic shock. Now, case 3. So you have a 56-year-old man who had a TK, total knee replacement, 7 days back, and coming with sudden onset breathlessness, and then collapse at home. And his pulse rate 120. Again, he's tachycardic and systolic blood pressure of 100. So it's borderline, but not hypotensive. His saturation is 88% of on-room air with clear lung fields. Now, what do you think? What's wrong with this patient? So you have a reduction of saturation of 88, but when you auscultate, you have a normal clear lung fields. So what could be this? So if you have, so then now again, this patient in shock stage and saturation low and have clear lung fields. So this is, unless proven otherwise, it's a pulmonary embolism. So that's why you have a clear lung fields. So saturation dropping down due to the shock stage, but you don't see here any lung sign. So if you have clear lung fields with low saturation shock stage, there are only few things you need to consider. Two things you need to consider. One is pulmonary embolism. Number 2 is severe metabolic acidosis, like septic shock. But there are no symptoms suggestive of sepsis. So this is, unless proven otherwise, is a pulmonary embolism. Again, patient in shock stage, and this is a obstructive shock. Case number 4. So 49-year-old man, he is non-patientonic ureteric stones, presents with loin pain, fever, and collapse. So what's the likely diagnosis? And again, his pulse rate 100, blood pressure 100 systolic, and he's flushed. So does this patient have shock? I mean, if you go with the parameters and the definition, he might not, but in overall, this patient again in early stage of shock. So what is this shock? So flushed, pulse rate of 100, and fever, loin pain. So this is a sepsis or a early septic shock, likely due to urine infection. So what are things you need to do? These are things you need to know, right? So you have to give enough crystalloids, is normal saline. You can go up to 30 mL per kg. that has to be given rapidly. So don't delay giving IV fluids till your seniors come. If you think of the sepsis, give it early as possible, within hour. And take your blood cultures and get a VBG and get other bloods, and then give the broad spectrum antibiotics to cover the infection. So these are things should happen at your level while you inform the seniors. Again, sepsis would kill if you delay identifying them. If you delay giving antibiotics by 1 hour, the mortality will go by about 7%. So it's extremely, I think it's a crime not to give antibiotic if you once you identify the septic shock. And one of the other thing I would like you all to do, once you chart the antibiotic, make sure the nurses give it, right? Because unless you tell, sometimes the nurses might not give, or nurses might waiting everything else to happen to you antibiotic. But again, you have to make sure that antibiotic will go once you charted it, right? So you have to make sure that you direct the nurses to give the antibiotic. So you will be having one of like the lectures for each and every this topic, but I'm just highlighting the important facts. Case 5. So it's a 20-year-old woman so in a hospital for pneumonia. So she was commenced on her first dose of intravenous penicillin, and suddenly complains of being hot and becomes hypotensive. So what is the likely diagnosis? Now her pulse rate is 100, systolic blood pressure of 100 again, but covered with urticaria. So there's a generalized urticaria. So does she have a shock? Yes, she has a shock, which is again a distributed kind of shock, which is anaphylaxis. So again, if you think of anaphylaxis, you have to give the medication, the life-saving medication at the earliest. So what are the signs of anaphylaxis? There are 4 systems involved. So if you have 2 of the systems involved, you can give it. So the skin, the rash, urticaria, the wheals, whatever, and angioedema. So these, and then you have the respiratory system involved, basically voice change, difficult breathing, wheezing, stridor, all are the respiratory system. This number 2 system involved. Number 3 is the cardiovascular system, which the patient can become tachycardic and hypotensive. That's the number 3 system. And the number 4 is the severe persisting gastrointestinal system, like persistent vomiting and persistent abdominal pain. So if you have 2 of the system involved, then it's anaphylaxis. You have to give the life-saving medication as early as possible. So what is the medication? So this is the patient which this would be a patient with anaphylaxis. Sometimes you might see once you start working. So the medication, the magical drug would be epinephrine. So adrenaline. So adrenaline has to be given intramuscular at the earliest as possible. So never delay giving adrenaline. If I ask what are the most important drug, number 1, number 2, and number 3 in anaphylaxis. So again, number 1 would be adrenaline, number 2 would be adrenaline, and number 3 would be adrenaline, right? So it's adrenaline, nothing else, right? And if someone dies of anaphylaxis, that's a medical negligence. No one should die with anaphylaxis due to anaphylaxis in the hospital, because you have to give them adrenaline early. So what my experience, some medical, some doctors and nurses would be extremely reluctant to give the adrenaline at the early stage, but give it early. Go. Yeah, go. I'll come there.
And where's the tape?
I'll come there.
Where's the tape?
Give me 5 minutes.
Wait, where's the tape?
Ask me, Ma. Right. Right. Sorry for that. Right. So in summary, so what I would like to highlight, shock is a stage clinical manifestation, basically signs of inadequate tissue perfusion at the cellular level. So there are various kind of pathophysiologies, and different disease process can lead to shock. But the final common pathway, where basically you will not get enough blood at the tissue levels. So if you don't treat, they will die. So you will be the one who decide the fate of the patient if you in shock. Shock is a continuation. Initially, patient would compensate, and if you don't identify and if you don't treat, patient will go into decompensed stage. And at one stage, whatever you do, the patient will die. That's why you have to give the treatment at early stage. So no point of giving every treatment after the patient go into the irreversible shock stage, where whatever you do, like whatever you start, whatever the machine you attach to the patient is going to die. So early treatment is really important in shock. So recognition of shock needs careful history and careful interpretation of vital signs, which I highlight. History is really important, and then I mentioned the important vital signs to look upon. So I would like to go through again. You have to check, you have to analyze the heart rate and blood pressure, analyze the shock index, analyze the urine output, analyze the skin, and analyze the brain, so the mentation level. So these are the clinical parameters you would be able to identify the shock stage. And to support and confirm your clinical assumption, you would need your blood results. As a bedside blood result, if you have a blood gas machine, you can check the lactate and by doing a VBG. And also, if you have ultrasound scan, which will be available in most of the emergency department and in major hospitals, you can do so many things to identify the cause of the shock and to guide your treatment, which you will be getting to know once you start working as a doctor. So that's the end of the lecture, basically. So again, I haven't gone much in depth of the management, which again you will get once you start your career. But most important thing I would like to highlight for you all, and I would like to keep in your mind. So you have to identify the shock early, and because you will be the first contact in most of the hospital wards. So if you don't identify, there will be a delay and there will be increased mortality and morbidity for these patients, right? So if you have any questions, you can write in the chat box. I would like to answer now. And also you can email me. So this is my email address, so miguelheva@yahoo.com. And if anyone will be anyone using Twitter, you can tweet me on at @miguelheva. So that's the end of the story. Right. So do we have any questions?
Right. Looks like no questions, Dr. Samil. Right. Thank you very much. That's Dr. Samil Galheva, consultant physician at.
Dr. Roshan, wait. I'm just running through the chat box.
Yeah, they have said anaphylaxis.
There are a few things I would like to highlight. So there's one question. So what is the diagnosis level of lactate for diagnosis? So if the lactate is more than 2, or you had to suspect shock. But if the lactate is more than 4, that's a confirmatory shock. But you have to do a repeat lactate level once you are given enough fluids to see whether the lactate has gone down. So basically, one lactate value will make you suspect, but you have to to monitor the treatment, monitor the IV fluids, you need to do a repeat lactate levels. And then, yeah, most of the things you have got correct. Shock stage, yes. So can we apply above shock classification to other shock except hypovolemic shock like septic shock? No, that the classification which I have mentioned, it's mainly for the hypovolemic shock, basically for the trauma. So it's a trauma classification which you can use in bleeding. So this classification will be used in bleeding only, not in other shock stage. But again, classification can be extremely unreliable. So make sure that you go with the things I have taught you. There's one more question, sir. In first case, if she's not elite athlete, can we say it's a shock because heart rate is 100 is normal for other people? Yeah, I mean, if this is a middle-aged patient, we might not be thinking of a shock unless there are other features. But extremely, if someone is known to have bradycardia, even the heart rate of 90 would be extremely alarming. So that's why I highlight being a young athlete, which heart rate of 100 is extremely worrying with those clinical picture. And septic anaphylactic shock, anaphylaxis. Right versus left heart failure, sir, what to do and not to do, sir. So basically, if you have a left heart failure, basically what the main problem would be, the patient would be having contractile issues. Basically, you can't pump the fluid out. So moreover you give fluid, the patient will be going to heart failure, and also there will be more pulmonary edema, because the heart will be accumulating from the left side of the heart will not be pumping fluid. Whatever the fluid you will give will be overloading the lung. So what you can do, if there's a left heart failure, what they really need is an agent to increase the contractility. So what they need is an inotrope. So basically, the dobutamine would be a better choice for this patient. But in contrary, in the right heart failure, now this is right heart failure. Once you get the right heart failure, basically the left heart will not be getting enough preload. So basically, the heart is not getting blood into the left side of the heart. So basically, what you can do is, so basically you have to pump fluid. So in if you have a right heart failure, you can give 2 to 3 liters of saline to increase the blood pressure. So that's the difference. The main difference in left heart failure, you can't give fluid. If you give fluid, the patient will be getting bad. So basically, you need to start a medication to increase the contractility. But in right heart failure, basically what you need is IV fluids, which will increase the cardiac output. So that's the difference. So yeah, can you repeat the email again? Yeah, so I will write my email address. So it's miguelheva@yahoo.com, which I just put in. So it's MIGELHEVA@yahoo.com. Can you please tell some examples of broad spectrum antibody which are using currently for shock? So broad spectrum wise, what we use commonly is meropenem and piperacillin tazobactam. So those are the two common antibiotics we use. But if you know the like the likely organisms like urinary tract infection, you will be given more specific antibiotics like ceftriaxone. So, sir, could you tell me about spinal shock with early management option? So what happened in spinal shock, basically the patient will be cutting off the sympathetic parameters. So basically they will be vasodilatory state. So what you need is, now when you have this, again a distributed kind of shock where you have normal amount of blood volume, but vasodilatory status. So what you can do, you have to give more fluids and you have to get the vasoconstricted stage. So you should start noradrenaline or adrenaline, which to get to the vasoconstricted state of the patient. So basically, in neurogenic shock, I mean, this has to be not spinal shock; it has to be a neurogenic shock. That's the correct terminology. So basically, the way to go would be IV fluids, enough IV fluids, and then vasoconstricted.